Welcome again for the medical student whom join us in this series of lecture in cardiovascular disease. Our lecture today is a common cardiac arrhythmia. This is the third lecture. Uh, to start with the heart block, which is first, second, and third degree heart block, atrioventricular block. If we look to the first heart block, the rate is variable. And P wave is normal, QRS normal shape and configuration. Conduction implies origin in SA node, but the AV junction conduction is the prolonged. That's why PR interval more than 0.2 second or 200 millisecond. As we know, normally PR interval is the 3 small square to 5 square. That's say is the 0.12 to the 0.2. But if you prolong that, which is first degree heart block, rhythm regular. This is the most common conduction disturbance. It's occur in both healthy and diseased heart. First degree AV block can be due to the myocardial infarction, especially inferior digitalis toxicity, hyperkalemia, increased vagal tone, acute traumatic fever, myocarditis. Just one point. If you remember every dysrhythmia, we mentioned digitalis toxicity. So digoxin toxicity can cause any type of arrhythmia except sinus tachycardia. Not cause sinus because AV nodal block, so it's not cause sinus tachycardia. And the intervention include treating the underlying cause in first degree heart block and observing for progression to more advanced IV block, which is unlikely. If we look to the ECG, PRQRS complex, PRQRS, PRQR, and regular equidistance between RR. But what's abnormal is the prolonged PR interval. It might reach near the T wave, so it is mild severe. So it is this prolonged PR interval. It's called first degree heart block. This is a first degree heart block. While a second degree heart block, AV block, two types. First type called MOPS type 1 or Wenckebach phenomenon. What's the Wenckebach phenomenon? Rate is variable. P wave normal morphology with a constant PP interval. QRS normal, but the PR interval is progressively longer until when P wave is blocked, not conducted, not preceded by not followed by QRS complex. The cycle begin again following block of P wave. Rhythm is regular. Second degree AV block type 1 occur in AVB node above the bundle of his. It's often transient and may be due to the acute inferior wall MI, even digitalis toxicity. Treatment usually not indicated, as this rhythm is usually produced no symptom, no hemodynamic. Look to this. If they look to the P wave QRS, P wave QRS, it's sinus. But this P wave is not followed by QRS complex. Come again, PR is normal, but little bit prolonged, and then prolonged until drop down. This cycle, if repeat itself, called Wenckebach phenomena, second degree heart block or MOPS type 2. This is a benign rhythm, really. While second degree AV block, MOPS type 2, this is a serious, high grade block. It's different from that. What to see is a rate variable, normal with constant PP like second degree Wenckebach, usually widen because this usually associated with bundle branch block. So the block at the first degree, Wenckebach, second degree, AV block MOPS type 1 at the above bundle office. This as bundle office or below. Conduction, PR interval may be normal or prolonged, but not repeat itself like second degree MOPS type 2. But it is a constant until one P wave is not conducted to ventricle. So it is constant, one P wave is not conducted. Rhythm usually regular when AV conduction ratios are constant. This block usually occurs below bundle of his and may progress to the higher degree IV block or heart block. It can occur after acute inferior wall myocardial infarction due to the damage to the bifurcation of bundle branch, left and right. It's more serious than type 1 Wenckebach. Treatment usually need a temporary pacemaker, then maybe permanent pacemaker. Otherwise, it degraded down to the more severe third degree or complete heart block. Look to that. This is a P wave. P wave. P wave not conducted. When it's conducted. P wave not conducted. P wave not when it's conducted. So this is what called second degree, while QRS complex little bit normal. Block MOPS type 2. Treatment usually pacing, either temporary or permanent. Well, the third degree heart block, what called complete heart block. Rate, atrial is usually normal. Ventricular rate is usually less than 70 beats per minute. The atrial rate is always faster than ventricular rate. The P wave normal with the constant PP interval, but not married to the QRS complex. I mean, the atria is contracted, depolarized by itself, and ventricle by QRS complex, it's by itself too. So it is not married. QRS may be normal or wide depending on whether the escape pacemaker is located in conduction system. Conduction, atrial and ventricular activities are unrelated due to the complete blocking of atrial impulse to the ventricle. While second degree AV block, not Wenckebach, second degree AV block, there is P wave, one P wave is conducted. There is nothing conducted in the complete heart block. The rhythm is irregular. On the venous wave, there is a giant A wave due to the contractions of the atrium and the block AV valve. Complete block of atrial impulse occur at AV junctions, common bundle or bilateral bundle blocks, or bundle branch blocks. Another pacemaker distal to the block take over in order to activate the ventricle, or ventricle standstill will occur. So there is others. We say it's any part of heart could be spontaneously depolarized. If the block, that some part of ventricle will be depolarized to maintain ventricular contractions. May be caused by digitalis toxicity, acute infection, MI, especially inferior, degeneration of conductive tissue due to the elderly. Treatment modalities include external pacing and atropine for acute symptomatic episode and permanent pacing for chronic complete. In acute, give atropine. An atropine test we can repeat every 10 minutes. If no response, with a temporary pacing for for a couple of days. Then if no response, do permanent pacing for a chronic complete heart block. If we look to this, the P wave, the atrium contracted independently of the ventricle. QRS complex usually abnormal. In contrary to second degree, there is one P wave is conducted. There is no P wave conducted. And come to the ventricular arrhythmias. To start with, the premature ventricular contraction is a group of pacemaker cells throughout the conducting system are capable of spontaneous depolarization. This is even into the atrial. The rate of depolarization decreases, from a conductive system, from SI node down to the Purkinje. So the rate of depolarization decreases from top SI node to the bottom down to the fastest at the sinoatrial node, slowest within the ventricle, and atria and AV nodes in between. Ectopic impulse from subsidiary pacemakers, another pacemaker, are normally suppressed by more rapid impulse from the above SA node. However, if an ectopic focus depolarizes early enough prior to atrial of the next sinus impulse, it may capture prior to the arrival of the next. This ectopic depolarization, if strong enough and early enough, it may capture the ventricle producing premature contraction. This is the basis and I mean hemodynamic, I mean the pathophysiology behind that, the how produce of premature ventricular contraction. Premature contraction or ectopics are classified by their origin. Atrial, we discuss in atrial, junctional, we have a time to discuss it, but ventricular, our subject today with ventricular tachycardia. Rate is variable. By the way, premature ventricular could be bigeminy, trigeminy, quadrigeminy. I will see what I mean by this. Rate is variable. P wave usually observed and obscured. No P wave because the impulse and originated in a ventricle, not passes from atria to the AV node to bundle of it. So it's obscured retrogradely. It will be, depolarize the atrium by QRS complex, PST, or T wave of premature ventricular contraction. QRS complex usually wide, more than 3 small square. Yeah, I mean more than 0.2 second or 120 millisecond. Morphology is bizarre shape with ST segment and T wave in opposite direction polarity of the QRS complex. Maybe multifocal, I mean different shape, exhibited at different morphologies. Conduction, the impulse originates below the branching portion of bundle of His. And the full compensatory pause is characteristic. We will discuss it here. Rhythm irregular, premature contractions may be occur in single, couplet, as we said, bigeminy, triplet, trigeminy, or the bigeminy, trigeminy, quadrigeminy. The premature ventricular contraction can occur in healthy heart. For example, an increased circulating catecholamine during stress and can cause premature ventricular contraction. They also occur in a disease heart and from drugs such as digitalis toxicities. Treatment is required if they are, this is not always, associated with acute MI. We will see how it's danger in the certain situation. Occur as a couplet, bigeminy, trigeminy, are the multifocal or are frequent more than 6 or 10 per minute. Intervention, lidocaine, class 1, propansteal, class 1, or quinidine. So if we look to this is the normal sinus, P wave QRS complex, P wave QRS. What follow by, this is, we don't expect it beat here, so it is prematurely. The P wave is abnormal, maybe birth here in a QRS complex. And the QRS complex is wide and bizarre. And T wave, ST T wave in opposite polarity, this upward, this downward, this upward, this downward. If we look to the every sinus, one beat, ectopic, every sinus, one beat, ectopic, every sinus, one beat. This is what called pulsus bigeminy. And it's followed by compensatory pause, post-ectopic, post-excitatory pause. And we will see it's a full compensatory pause. What mean by full, we will discuss it in the coming slide. Ectopic firing of focus within ventricle bypass the His-Purkinje system and depolarize the ventricle directly. That is why the QRS complex is bizarre and wide. This disrupts the normal sequence of cardiac activation, as we know, from SA node down ventricle, leading asynchronous activation of the two ventricles. I mean right different from the left. The consequent interventricular conduction delay produce QRS complex with a prolonged duration and abnormal morphology. If we look to that, this is sinus, this ectopic. Sinus, this ectopic. Ectopic because it's prematurely, there is a compensatory pause, bizarre wide QRS complex. If we remember, atrial contraction is normal QRS complex. P wave is birth there after QRS complex, and direction of STT wave in different, in the opposite direction of the QRS complex. This is what mean by the complete compensatory pause. It means that if we measure the distance between this sinus, ectopic and sinus, the distance here is double RR of a sinus. That is we call complete compensatory pause. The RR interval, if we measure it, if RR interval in between ectopics, this is double this period. This is not seen in atrial. If you remember, we said it's not complete compensatory pause. This is complete post-excitatory pause. This is a previous slide we discussed it. This is the normal, and this is the normal, and this is atrial ectopic. And this is atrial ectopic. This is atrial ectopic. Why? There is a P wave different from normal P wave. QRS complex normal. There is no STT wave. And compensatory pause is not complete. If we measure RR there, it's not double. I mean, this interval, the R, ectopic R, the interval not double RR normal. This is the atrial, premature atrial contraction. So this ventricle originated there in the ventricle. That's why depolarize and activation in the ventricle. And this is the Pizarro QRS complex. No P wave, either burden there or there. And the wide QRS complex and the STT wave in different polarity, opposite polarity of R wave. And if we look to the morphology then and the shape, this ectopic different from this ectopic and different from this ectopic. If it's negative, I mean S wave, it's upward. If it is R wave positive, the STT wave in the opposite direction downward. This is upward because the S is dominant. This is that the morphology is different and the similar morphology. This is what called multifocal, not from the same focus. So premature ventricular contractions often occur in repeating patterns. Bigeminy, every other beat is the premature beat. Trigeminy, every other third, there is one ectopic. Quadrigeminy, every fourth. Couplet, 2 consecutive beat. Triplet, 3 consecutive beat. And the frequent and the symptomatic premature may be due to frequent or symptomatic, while infrequent is very common. Anxiety, sympathomimetic, beta agonist, and excess caffeine, hypokalemia, hypomagnesemia, digoxin toxicity, myocardial ischemia. Multifocal ventricular contraction is the sinus rhythm with the premature contractions of two different morphologies, as we say in the previous diagram. Note that morphology is different, and the STT wave, if it's R wave up, it's down. If the S wave first, so it is up. And this is the ventricular bigeminy, sinus ectopic, sinus ectopic, sinus ectopic. This is sinus, sinus, sinus ectopic, sinus, sinus. Every 3/4 is called the quadrigeminy, and the same morphology, the same morphology. It's not multifocal, unifocal. Premature ventricular contractions are dangerous when they are frequent, more than 3% of complexes. Increase in frequency. They come close to or on top of T wave, R on T. What's meant by R on T? The R wave of QRS complex near the T wave of sinus beat. On it or near. This phenomena usually vulnerable period. This is very excitable period, lead to the ventricular tachycardia. If not treated with time, lead to the VF, even standstill, even death. This is a serious R on T. 3 or more premature in a row, run of VT, called non-sustained, come 1, 2, 3, 4, 3 and above, less than 30 seconds, less than half a minute, was called non-sustained VT. Acute, any premature ventricular contraction in a setting of acute MI, not usually, but usually it's more frequent, so you have to treat it. Premature ventricular contraction come from different foci, multifocal and the multiformed, multi-shaped, multimorphology. These may result in a ventricular tachycardia, even or ventricular fibrillations. Causes of ectopic foci and beats in general, atrial and ventricular, hypoxemia of myocardium, chronic pulmonary disease, pulmonary embolism, ischemia of myocardium like MI, sympathetic stimulation, nervousness, exercise, heart failure, hyperthyroidism, drug electrolyte like the digoxin and hypokalemia, hypomagnesemia, and so on. Bradycardia, slow heart rate predisposed to one arrhythmia, enlargement of atria or ventricle producing stretching. Come to that, the first serious rhythm, which is called ventricular tachycardia. Rate usually between 100 to 100, more than 200 beats per minute. Can be raised up to the 250. P-wave obscure, if present, are unrelated to QRS complex because that the focus of re-entry mechanism there in the ventricle, so there is no P-wave. Sometimes is retrogradely the impulse passed to AV node to atrium retrograde and stimulate it. The T-wave is P-wave is coming in the QRS complex. Wide and bizarre shape morphology of QRS complex. Conduction as with and rhythm, there three or more ventricular beats in a row, as we called it, non-sustained VT, and may be regular or irregular, usually irregular. Ventricular tachycardia almost always occur in heart disease. There is no VT normal. It's a serious rhythm. So in any types of arrhythmia, if develop hemodynamic instability, hypotension, shock, loss of consciousness, reduce in cardiac output, is serious. In VT, it might produce hemodynamic stability. Some common causes: coronary heart disease, congenital heart disease, acute MI, digitalis toxicity, congestive heart failure, ventricular aneurysm, drugs even. Patients are often symptomatic with this dysrhythmia. Ventricular tachycardia can quickly deteriorate into the ventricular fibrillation and hemodynamic instability, even death. Electrical counter shock is the intervention of choice. We mean DC if the patient is symptomatic and rapidly deteriorated. Some pharmacological intervention include lidocaine, pronistil, and pretilium, brocanamide, and so on. And this is monomorphic VT. If you look, there is no P-wave, isoelectric line, and the QRS complex wide and bizarre, but the same direction, what called that the monomorphic ventricular tachycardia, the same shape. And this is VT, and need urgently to give a DC. Most of patients are hemodynamically unstable. What mean by torsade de poids? Torsade de poids is a French medical terms, is used to that the types of VT as we discussed previously, but it's a polymorphic VT. Rate usually between 150 to 120. P-wave obscure in present, in past. QRS complex, if present, the P-wave. QRS complex wide and bizarre morphology. Conduction, as with the premature ventricular conduction, rhythm is irregular, paroxysmal, starting and stopping suddenly. Hallmark of this rhythm is upward and downward oscillating deflection of points of QRS complex around the baseline. The term is torsade de poids, meaning twisting about the points. Consider it ventricular tachycardia if doesn't respond to antiarrhythmic therapy or treatment, caused by drugs which cause prolonged QT interval or already prolonged QT interval, such as quinidine, hydroxychloroquine, electrolyte imbalance, particularly hypokalemia, myocardial ischemia. Treatment synchronized DC is indicated when the patient is unstable. IV magnesium for prolonged QT interval, IV potassium to correct electrolyte imbalance, and overdrive pacing sometimes we need. If we look to the sinus, and this is oscillating point around the baseline. This is that the not the same morphology. It's polymorphic, not called torsade de poids. And the ventricular fibrillation, the most serious rhythm. And it means in VF is a physiological death. It means intervention within 1-2 minutes. Otherwise, the patient go to standstill and die. So ventricular fibrillation is serious. The most common cause of death in acute MI, as we said, arrhythmia. The most common arrhythmia is the VF that causes the death. Rate unattainable. P wave may be present, but usually not. But not P wave anymore. QRS complex not apparent. Conduction chaotic or chaos electrical activity. Rhythm chaotic electrical activity. This dysrhythmia result in the absence of cardiac output. Usually the patient hypotension, there is no pulse, unconscious, almost always occur with a serious heart disease, especially acute MI. The course of treatment for ventricular fibrillation, immediate defibrillation, and according to the ECLIS protocols. Anyhow, immediate defibrillation. Identification and treatment of underlying cause. If it's repeated after cardioversion and put a xylocaine drip, check underlying cause, check hypoxia and electrolyte, especially hypokalemia. Look to this, the chaoses up and down. There is no QRS complex, there is no, P wave, and the patient usually hemodynamically unstable, unconscious, blood pressure zero, pulse rate zero. This is what's called ventricular fibrillation, the more serious rhythm. Ventricular standstill or asystole, if fibrillation not treated, it will become like straight line. The rate none may be seen, but there is no ventricular response, QRS none, conduction none, rhythm none, asystole of longer duration. It means the presence of acute MI and the coronary heart disease is frequently fatal. If it's prolonged in the ischemic heart disease, it's fatal. Intervention, cardiopulmonary resuscitation, not DC. Artificial pacing may need atropine sometimes benefit. This is the straight line. If it's prolonged enough in end-stage failure, this is what's called ventricular asystole on the standstill. And this is non-sustained VT. What means non-sustained? There is sequence of premature ectopic, less than 30 seconds, and then sinus. This is what called types of ventricular tachycardia, but non-sustained. Run of the VT, one of the serious arrhythmia, as we said, ventricular. And this is non-sustained monomorphic, the same. And the ectopic, then less than 30 seconds, then sinus. This is non-sustained polymorphic. Look, it's different from this speed and this speed. Coming 1, 2, 3, and then sinus. Coming 3 and capture sinus. And different morphology is non-sustained VT, but polymorphic. This sustained monomorphic. Look to that, the same QRS complex. There is no P wave, rate about 200. And this is the VT monomorphic. This is sustained polymorphic. This QRS complex is different from one to another. This is sustained VT and the polymorphic, different morphology. VT with defibrillation and VF, this VF and give defibrillation, respond few and then no responding. And ventricular tachycardia, if impulse is initiated from the ventricle itself, wide QRS complex in range 120 or 40 to even 250. If unstable, DC cardio, wait right away. If not, IV amiodarone and or the cardioversions, DC cardioversion. Consider procainamide first class. Non-sustained ventricular tachycardia need treatment. As we said, it might degenerate to the VF. And this is that the VF, an example of ventricular fibrillation. Torsade de poids is the oscillating point around the baseline. This is that the torsade de poids due to that the quinidine and that caused by medication like quinidine, disopyramide, sotalol, beta blocker, and so on. Ventricular fibrillation as well is most common acute MI, most serious disease, the most common cause of death. Also drug overdose, anesthesia, hypothermia, electric shock can precipitate VF and death. Absence of ventricular response, usually terminal event, serious rhythm. If we don't interfere within a few 2 minutes, it's called physiological death. So use amiodarone sometimes if refractory to the DC, as we said, correct electrolyte, correct hypoxia. And this is like the monomorphic VT. Sinus, and then monomorphic VT. And the monomorphic ventricular tachycardia. This is monomorphic on the non-sustained VT. This is non-sustained monomorphic VT. This is VF, ventricular fibrillation. And rhythm associated with sudden cardiac death, ventricular fibrillation, asystole, and ventricular tachycardia. These might be associated with sudden cardiac death. Other causes of sudden cardiac death: airway obstruction, acute pulmonary embolism, acute pericardial tamponade, acute myocardial rupture, aortic dissection. This other cause in differential diagnosis of sudden cardiac death. If we remember, we discussed cardiomyopathy, hypertrophic cardiomyopathy in young adult athletes, and right ventricular dysplasia, arrhythmogenic, can cause of the sudden cardiac death. The monomorphic VT, and this is non-sustained VT, less than 30 if we calculate the times, less than 30 seconds. Polymorphic VT, we give a lot of examples because they're serious and important to know it. Torsade de poids, due to the prolonged QT interval and oscillating point, types of polymorphic tachycardia. These spills and or syncope patient due to the arrhythmia, due to the bradyarrhythmias. Sinus bradyarrhythmia less than 40, sinus arrest with low junctional or ventricular escape less than 40. Second or third degree heart block might present with this atrial fibrillation flutter with the slow ventricular response and rapid. And this spill and syncope tachyarrhythmia produce supraventricular tachycardia. Tachycardia is very rapid rate. Ventricular tachycardia. Non-arrhythmogenic cause of syncope, orthostatic hypotension, vasovagal reflex, left ventricular outflow, tract obstruction, aortic stenosis, hypertrophic cardiomyopathy, large pulmonary embolism, left atrial myxoma. Management of symptomatic supraventricular arrhythmia. See you soon. This is the last slide in this lecture.